Kevin Bailey oversees a range of work across the substance use agenda in the Public Health Agency. Kevin works in partnership with the community, voluntary and statutory partners to implement the substance use strategy. And a friend of ARC, so can we please give a warm round of applause for Kevin Bailey.
Everyone, can you hear me okay? Lord, I was right. It's very disconcerting having your face up there. It's great to be here today, folks. And for the next sort of few minutes, I'm conscious there's a clock going down there for 20 minutes. But Gary told me I can talk longer if I wish. And Paul said he was okay with that, so I might do that. But for the next few minutes, I want to talk to you about addiction, shame, and trauma. And we've heard some of that already. And I know we've experienced that in this room. But importantly, we also want to talk about the role that the substance use strategy that Lord mentioned earlier on, preventing harm, empowering recovery, a strategic framework to tackle the harm from substance use, and also the substance use strategic commissioning framework and implementation plan that we put together to direct our work for the next number of years. We want to talk about how they can play an important role in creating better societal understanding about addiction, while also reducing shame and stigma. And the way in which we're going to do that is through a trauma-informed and responsive whole system approach. And as we go through the presentation, I'm going to ask you to consider how the conceptualizations of addiction that I'll present either fits with or potentially differs from your own ideas and experiences. And I actively invite you to be curious about what you notice. And ideally, be curious without judgment. So, there are lots of different definitions, aren't there, in relation to the work and the world of addictions. So I can see we have our first slide up. Hopefully this works. Some of the definitions I'm going to use, though, for this presentation are up on the screen there. And when you think about addiction, that idea that any type of behaviour that a person finds potentially either pleasure or relief, but also craves, and at the same time suffers a negative consequence, but yet can't give that up. That's from Gabor Mate. Many of you will have heard of Gabor Mate, a world-renowned speaker. And he also, for me, picks out the next definition around trauma. It's a loss of connection to oneself and also to the present moment. And isn't that what addiction is? A loss of connection to the self and to the present moment, because we're often trying to escape whatever trauma that we're experiencing. One of the things that we'll talk about through this presentation is around the idea of attachment. And attachment was formed a long, long time ago in terms of a theory. And John Bowlby, who developed that, talked about attachment being a lasting psychological connectedness between human beings. And we've heard a great deal already, haven't we, today, about connection and how important that is, how it fosters hope. One of the things that stands in the way of some of that connection is shame. And there's lots of shame associated with addiction. And again, lots of different definitions, but I've put up Brené Brown's definition there of shame. And that's the intensely painful feeling that we're not worthy of love and belonging. And sure, if we're not worthy, why do we try? Why do we just engage in alcohol and drugs? Because that makes us at least feel something, or it helps us escape from that. And I also think it's important to note, and some of you will be aware of this as well, that the physical pain that we experience and the emotional pain that we experience, they're experienced in the same part of the brain. So the anterior insula and also the anterior cingulate cortex, that's the area of the brain, just a U shape, if you can imagine, just right behind the frontal cortex that helps us experience both that physical and emotional pain. And alcohol and drugs and other substances are the things that help us overcome, at times, it seems, some of that, but not without risk and not without consequence. So one of the things I think we need to think about as a society in Northern Ireland is a social cultural model of addiction. And that model of addiction examines substance use and substance use disorders in light of social and environmental influences. And I think we've already heard it on the stage today. No one wakes up of a morning and says, I want to be addicted to a substance today. That's not something we do. It's not something we aspire to. There are lots of things that influence that. And so this social cultural model of addiction, it posits that there are cultural standards, societal influences, and they play a big and significant role in causing and maintaining addiction. And it also considers wider social structures. So, for example, our family, our community. It also considers institutions, so religion, education, the law, and also inequalities that we experience across our communities, poverty, housing, employment, health, and how they all impact substance use and also its effects on different social groups. And this perspective really encourages us to look beyond the individual and consider the wider societal factors. And as you can see on the screen there, we know that genetics are important, but there's something about the environment and nurturing and how that's imperative. And I've put up there that that's about the child's life, because often we haven't got enough of these things in childhood that influences our behaviour in adulthood. So if we're not getting enough nutrition, physical security, and consistent emotional nurturing, which we'll talk about later, that has a real impact on us. And it often causes us distress or psychological discomfort. Sometimes we know that, but sometimes it happens to us, and sometimes without our knowledge. And when those things occur, that helps us or indicates that we will try to find relief from that physical, emotional, or environmental pain. And the answer is often through substances. And to quote Gabor Mate again, he says, the question is never why the addiction, but why the pain. And why the pain often involves the fact that trauma is at large in our community, individually, in families, and in communities. And there's definitely a robust correlation in the scientific literature between trauma and addiction. And when you think about different types of trauma, there might be things like shock, so a single incident, witnessing a car accident, for example, or developmental trauma, which often happens in early life when the brain is still developing. That includes things like ruptures in attachment relationships, so those relationships we have with our caregivers. And they're usually not life-threatening. But then developmental traumas can also occur. And they also are ruptures in attachment. And our survival is also threatened in some way. And often that's potentially through neglect or abuse. And we've also got complex trauma as well. Repeated chronic experiences of developmental and or shock trauma. And those impacts of childhood trauma, they're nuanced and complex. But yet there's one common outcome in that, and that's dysregulation of the stress system. And when we have that dysregulation, that can lead to depersonalization, it can lead to numbness, and it also may increase our vulnerability. And the way out of that is by having a trauma-informed and responsive approach to the conceptualization and the treatment of addiction. And we've heard that already. We need to think about addiction differently as we move in to treatment of individuals and through to recovery. Now, with that, it's not all bad. Some of our impacts, positive and negative, start off with attachment. And some of you will have heard about attachment. And as I say, John Bowlby developed this theory way back in the 50s, in 1958. And really it came about in an opportunity to try and understand more about human relationships. How do we connect with each other? And what Bowlby was saying is that those connections we can build in childhood, they're really critical to our emotional development. They lay the foundations for all relationships in the future. And according to Bowlby, individuals can either display secure or insecure attachments to one another. And affect can offer a huge insight to our past early experiences. It can also be useful when we consider addiction, helping us to better understand how substance use through to dependence may have manifested, as well as potential triggers then, which can often result in relapse. And I want you to, for a minute, just to consider, without judgment, what's some of the attachments you might have had as a child? You think about secure attachments. Often that's individuals who have usually been brought up in a safe environment with a stable primary caregiver, and they turn to support. And those individuals who have that attachment style often tend to hold a positive image of themselves and others, and they can maintain relationships that are healthy and balanced. However, there are a number of elements around insecure attachment, a number of subtypes, if you will. There's avoidant attachment, and that's where that person potentially will hold a positive perception of themselves and a negative image of those around them. And often that generally comes from being in an unstable environment as a child, having inconsistent care from a guardian. And the avoidant child can grow up to become really wary of close or committed relationships and often deflect from their own feelings. They avoid conflict. Some of those key traits might be, for example, maintaining a safe distance from other people. Might even be unlikely to seek help in times of need. Potentially fear of intimacy. And then almost the reversal of that, we've got anxious attachment. And in that case, individuals with anxious attachment, they often hold a negative image of themselves, but a positive view of the world around them and others, and typically feel unworthy and undeserving of love. Some of those aspects that we might see associated with an anxious attachment is fear of abandonment, intense need for validation, often looking outward, and insecurity in relationships. And then we've got the third aspect there of attachment is disorganized or fearful. And those individuals that have that experience tend to hold a negative view of both themselves and the world around them. And growing up, there was a source of fear and insecurity. And that's led to difficulty in trusting individuals around them. But also at the same time having a strong desire for approval. And that can display in our relationships with family, with friends, and others around them. And when you think about somebody who's had that disorganized, fearful attachment, sometimes they really seek out really intense closeness with individuals, or the opposite, really extreme separation with no in between. They've got fears of other people's intentions, and they are uncomfortable in expressing affection. And when you think about that, that can lead to a number of things, like self-medicating. You know, when you think about it, some of us will have turned to substance use to escape reality. Or potentially we might feel that taking part in compulsive behaviours helps distract our mind from difficult emotions. Or that we feel that we're really calm when we're under the influence of substance, and that's the only thing that works. Equally, we might engage in codependent relationships to feel secure. And when you think about that, some of the traits of that is that sometimes we might put our loved ones on pedestals, almost believing that they're somehow too good for us. We don't deserve them. Or we're frequently putting the needs of others before our own. Or that we panic when a loved one is going to leave or is maybe being a bit distant from us. And when you think about all the various opportunities in there to have those negative impacts, it's really understandable how alcohol, drugs, and other substances can be appealing. Because it stops some of that, doesn't it? It balances some of that in our view, but we know in reality it doesn't often. And one of the things that really impacts then us reaching out and asking for help and seeking that help is shame. And when we think about shame and addiction, there are lots of different psychological conditions, including addictions, where shame responses often come from core distress or pathology. Yet, even though we know that, shame is often hidden, or indeed it remains unacknowledged at times. And actually what we do is rather than recognize the shame, attention's often drawn to defensive and coping responses to shame that maybe appear as the primary issue rather than the secondary. And these may include things like, for example, verbally attacking others, or potentially attacking the self, or withdrawal, or maybe even avoidance entirely. And as with other emotions, shame really can be a fleeting experience, although it may be repeatedly activated to produce a mood or a state that may appear as a personality trait, almost that it's always ever present for us. So, for example, we might misinterpret an attack on others' response to shame as a person's need for anger management. You can see the connection, since individuals prone to use this response tend to lash out the others, or they blame others, or they hide what way they feel. The reverse is also true in that we attack the self. And if we're directing responses of anger towards the self, appearing maybe as self-loathing, so really strong feelings of dislike, maybe even to the point where we might hate ourselves, or extreme criticism, or potentially we engage in self-interest behaviour. And withdrawal may also be understood as depression or isolation. Avoidant responses may appear as denial, since they remove intense feelings of shame from conscious awareness. And when we think about that, there's a number of things I would ask us to consider. One of those is up on the screen there, the bottom bullet point, and that's the 4 S's of secure attachment that was originally developed by Dan Siegel. And what Dan Siegel says is that we need enough of those 4 things as children in order to develop as healthy adults. So we need to feel safe. We need to be seen for who we are, not our issue, not our problem. And Gary very eloquently highlighted that this morning. We need to be able to be soothed in some way, both by individuals around us, but also by ourselves. And we need to feel a secure attachment. Imagine, if you will, what it would be like if we were safe, seen, soothed, and secure. We would have healthy bonds in adulthood. We may not turn to a range of substances to get some of those feelings. Another way that we can overcome shame is by the use of empathy. And empathy is a hostile environment for shame. And to re-quote Bernie Brown, shame thrives when we feel most alone, cut off and separate, and different from those closest to us. Shame happens in the gaps between people. However, when separation is removed or lessened, the feeling loses its power over us. And really, that creates the conditions for hope and recovery together. The theme of this conference. So with people around us, we can move through those issues of addiction, of shame, and attachment. And I suppose one of the things I want to talk to you about just for the last couple of slides is the context by how we're going to do that from a planning perspective. Lorna already mentioned this morning the substance use strategy, which you can see up there on the left. And also I mentioned that really nice, easy phrase that comes off the tongue, the Substance Use Strategic Commissioning and Implementation Plan, otherwise known as the plan for short. That's a document and a process that we've went through regionally over the past number of months, probably about 18 months. And the plan was co-produced with over 150 organisations across the community, voluntary and statutory sector, but importantly, with individuals with lived and living experience in the room. And that plan itself, that sets out a number of actions we're going to take forward over the next 4 years. But I do believe what we do matters. However, in my view, how we do it matters more. And I suppose then, as part of that process, we set out a range of principles by how we will go about our work. And you can see up there on the screen that idea that human rights is an embedded, fundamental approach to how we work through the next number of years with our services. You can see partnership working, co-production, and shared responsibility up there. No one organisation or one individual can do all of this on their own. They need collaboration. And we're pretty good at doing that in most parts. And there's other areas that we can improve on through our work. We have to be inclusive around our health. So no matter who the individuals are, no matter what their experiences have been, they should be in the room. That whole idea of nothing about us without us is really important in this approach. And we need to have our services backed up by research, evidence, and evaluation. And we need to strive for continuous quality improvement. If we want people to come through our processes of treatment-oriented services into recovery, we have to allow them, enable them to really clearly define what recovery means for them. And it's going to mean something different for every individual person. And as a commissioner, there's a challenge in there for me around not setting KPIs and targets that might make sense to me but not sense to the individual. And there's a meeting in the middle there we need to think about. How do we do that most appropriately? We're going to look at that through... Oh, we're not going to look at that. That doesn't want to work. Load up. I can hear it. Oh, no, there we are. We're going to look at that through a range of different priorities. And I'm not going to go through all of those up there, but I suppose one of the things I would point out to you, within the priority setting process that we've engaged in around the plan, prevention is key. When we can't prevent people from engaging in substance use, early intervention is really important. Having the right pathway and the right model of care for individuals is crucial. Not a one-size-fits-all. A unique experience for individuals that they can benefit from. Having a system that's thinking whole system, acting whole system, and being trauma-informed is crucial. And one that really challenges stigma in a way that is meaningful and is everlasting. And within that as well, we also need to think about our workforce, which is key. We've got lots of people working across community, voluntary, and statutory and private organisations that for them, this isn't a job, it's a vocation. So there's lots of dedicated people in there, and we know the system struggles. So we need to think about how do we help those individuals those workers across the system, be they a frontline practitioner, be they a chief executive in an organisation, to make sure that we're taking the right decisions at the right time. But also, how do we embed individuals with lived and living experience into that process? Because ultimately, they're the experts by experience. And we have to have that cohort as part of our workforce as well, and engaging in a way that makes most sense. So in terms of the next steps that we're going to look at regionally, we're going to look at the agreement of those implementation structures, and we're going to consider regional work streams being established in October, looking at prevention, looking at pathways, looking at person-centred care, looking at people, so our workforce, and also performance improvement. And I hope this presentation this afternoon has provided a really brief glimpse into the complex area of addiction, shame and trauma. There's much to consider in the areas beyond the scope of this presentation, and I would encourage everyone in the audience today to pursue ongoing learning in each of these areas. And just to finish up with a couple of points for me that's important to remember, and that's that nobody wakes up of a morning wanting or wishing to be addicted to a substance. I think we need to hold that as a fundamental understanding and awareness. And all behaviour, including addiction, makes sense. And we can learn to better understand individuals through a compassionate approach. I often think about how would I want to be treated if I'm entering that service. And I want to be treated with care, with respect, and with compassion. And I guess that's the process I think I encourage all of our providers to engage in, and also individuals with lived experience to hold us to account and make sure that we're doing that in a collaborative way. So I've just gone over time, folks, so thank you very much. I hope you enjoy the rest of the conference.